Okay. All right. Hello, everyone. My name is Javier Lorenzo. I'm the clinical associate professor, and today I'm going to talk to you guys about oxygen transport. I am counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Is this the usual number, or do we need to wait a little longer? Also, I will say that it is great if you can turn your videos on. It's wonderful to see faces when I'm lecturing. Otherwise, I just see the little black boxes. I also understand that not everyone is in a position to share their video, but if you can, that'd be great. All right, oxygen transport. This is a topic that is high yield. You'll get asked not just about oxygen delivery. There's a couple of equations that the boards love to test you on, but the actual structure of the hemoglobin, as well as hemoglobinopathies, are also a favorite topic of your boards, as well as changes to your oxygen dissociation, hemoglobin dissociation curve, changes to the left, changes to the right. That also seems to be a pretty high yield topic. So at the very least, you can always count on a question with that curve. You can always count on a question with oxygen delivery equation. So study that. That's high yield. Okay, so you're in the ICU and you get called urgently because there's an 84-year-old who recently underwent spine surgery, and he's altered, he's hypoxic on a non-rebreather mask, his abdomen is distended, and he's not following commands. This morning, he was in room air. They just did an ABG, and the reading is 7.17, 68, PO2 of 55. Could be venous. The fellow's not sure. He wasn't there when this was done, but immediately you say, get an x-ray. I'll be there bedside. And this is what the x-ray shows. So anybody want to give me a wet read on this x-ray? This is the fun part. This is where I can call someone. If you show your video, I won't call on you. Franklin, what do you see on this x-ray?
So it looks like it's portable up at the top left.
Mm-hmm.
See the left and right. It looks like, obviously I see the hardware, the surgical hardware. It looks like a wide mediastinum as well.
Okay, maybe a wide mediastinum, but it is a portable, study, so you don't know how close the source was placed to the patient. So that's always difficult to judge. What else comes to mind? Anything else?
The lung volumes look smaller.
Yeah, the lung volumes look really small. Actually, strikingly small on X-ray, but when you are standing next to the patient and you notice that the patient is actually 6'5", you're like, this looks really small. What is one way in which you can judge lung volumes?
Counting the rib spaces.
Okay, so count the ribs posteriorly. So you want to see them, and if you do count the ribs, how many ribs are you counting?
Let me see. 1, 2, 3, 4, 5, maybe 6 on the left.
Exactly. I would say 5.5. And I would say that in a normal spontaneously ventilating patient, particularly in somebody that is 6'4", you want to at least see 8 to 10. If they take a deep inspiratory effort and they hold it, you might even see more. But of course, you're in the ICU, you're semi-recumbent, you're somewhat sedated, so that's going to be somewhat limited. 5 ribs on a portable X-ray on a 6'4" patient, those are tiny lung volumes. What else in this X-ray makes you think might be contributing to the low lung volumes? And Franklin, I call a friend. Like, it's not all on you. Okay. Brian, Justin, Katie, anything else on this X-ray?
There's some bowel gas, maybe.
What's that? All right, so you see air here in the abdomen. It doesn't look like it's free air, but you see a lot of air, more so than you would expect. And you're like, okay, let's just take another X-ray let's do a KUB, and you follow it up with this. And now you're like, okay, that's a lot of air. In fact, you take another X-ray of the KUB and you notice that the colon is dilated to almost 16 centimeters. And what is the upper level normal of colonic distension? Well,
9 centimeters?
9 centimeters. Yeah, who said 9 centimeters?
I did, Frank.
Frank, yeah, 9 centimeters, a little bit larger in the cecum, but anything over 9 centimeters in the colon, you're starting to worry, why is my colon distended? This guy is, almost double that. So he has colonic distension, which in fact, it is pushing up on his belly. It is pushing up on his diaphragm. It's giving him a restrictive physiology and is decreasing his lung volumes. And because he's so deconditioned and because he is post-op, there's also the question of whether, particularly high on the cervical, you wonder, is there any kind of phrenic nerve damage or any nerve damage that may have actually contributed to his elevated diaphragm? But in this case, it's pretty clear that the intra-abdominal process is probably what's causing his restrictive physiology. All right, so then you go ahead and you decompress, and now you see that the air is evacuated. He's intubated. You see there's a tube. You had to intubate him because he was in respiratory failure, but now you count the ribs. Now this is a normal, not spontaneous breath, it's mechanically delivered breath, but now you can see 8 ribs and the 8 counter ribs posteriorly. And you also don't see that bibasilar atelectasis that you saw earlier. All these haziness is actually much cleared out now, and you see the diaphragm border a little bit sharper. Okay, so compare those 2 x-rays, and then you realize how tiny those lung volumes were because of the abdominal process. And essentially what was happening is that this patient was developing colonic pseudoobstruction, which gave him abdominal compartment syndrome. And abdominal compartment syndrome, it's a clinical definition, but it is clinical definition that is based on a real number. So if you have the chance to monitor and measure the abdominal compartment, the abdominal pressure, which we do by laying the patient supine, relaxing the patient, and measuring the bladder pressure. And that abdominal pressure is transmitted into the bladder pressure. And if that pressure is more than 20 millimeters of mercury, then it is suggestive of abdominal hypertension. And it could have a wide constellation of manifestations clinically. And the ones that it was evident on this patient is that it really greatly affected his compliance. It increased it worsened his mismatch. It increased his work of breathing. It made it much more challenging for him to breathe by having that restrictive physiology. And it wasn't until you decompress him that he actually improved. But it affects a lot of other organs, not just those intra-abdominal organs. And I start with this case because the question of transport of oxygen from the atmosphere until it reaches our mitochondria, which is where the transport, which is why we care about the delivery of oxygen, that our organs and our cells are going down that glycolytic pathway, that electron transport chain, where the most number of ATPs are produced to maximize energy production. That is affected by many, many factors. And in this particular patient, it was affected by a distended colon. So just think about, systems issues and systems when you think about the care of these critically ill patients. Okay, so why we care, I think I mentioned this, we care about oxygen because we need it for energy. We are hypoxic for a long time. It can lead to organ dysfunction. It can even lead to death. We get our ATPs from, oxygen that goes down the glycolytic pathway and then eventually enters the electron transport chain. And we just need it to survive. That's how, there's no more to that. As preoperative physician, that's probably what we do. A lot of it in the OR is ensuring that oxygen is transported to tissue and the tissues are adequately using that oxygen. I think I already mentioned the consequences of hypoxia. All right, so you're looking at the oxygen cascade, which is essentially a little bit of a distance travel, an oxygen molecule going all the way from air, assuming you're at sea level, all the way down into mitochondria. So it's the drop in oxygen tension as you enter many of these different compartments. So we know that 21% of our air is air. What are the other gases in air besides oxygen?
Nitrogen.
Nitrogen. Yeah, it's mostly nitrogen. Anything else?
like argon, other minor gases?
Yeah, there's a little bit of CO2. Actually, there's less CO2 in the environment. There's more CO2 the more we enter our lungs, the closer we get to the alveola. But that drop of air of 150 in the air to close to 100 in the alveola, why is there that sudden drop? What is driving that drop?
The vapor pressure of water.
Yeah, it's a vapor pressure of water. In fact, you might recognize this this equation. What's the name of this equation? Somebody else other than Frank.
Alveolar gas equation.
Yeah, the alveolar gas equation. So the alveolar gas equation subtracts that vapor pressure of water, which is present in your large airways, all the way distal. So it's present. It's estimated to be 47 centimeters, 47 millimeters of mercury. It is affected by your barometric pressure. So the percentage of the water pressure increases as you go higher in the altitude. Excuse me, guys. My Portuguese water dog has not been walked in a few hours, so he's going to jump on me today. All right. So eventually, the alveola is picked up by your end capillaries, your pulmonary capillaries. It's delivered into your arterial blood, and then delivered into your tissue capillary. It enters your cell, it enters your mitochondria, and then participates in the electron transport chain. So think about any pathology that happens all the way from the entry into the air, which could be not enough oxygen, high altitude, all the way down into your mitochondria disorders. Anything in that transport chain could have consequence to your delivery of transport, the delivery of oxygen. And again, this is just what I was talking about, that as your barometric pressure decreases, because you might be going higher in altitude, the percentage of drop that is attributed to your water pressure increases. When we're at sea level, that drop is very clinically insignificant. It's about 6%. It's a drop from 150 to 100. But when you're at the top of Mount Everest, that drop could be as much as 20%. So it's very clinically significant. And again, this is the reason why we care about oxygen transport. We want oxygen to go down this pathway, to be involved in the electron transport chain to maximize our ATP production. All right, so again, this is just another way of showing that oxygen cascade. So the uptick in lungs, the way the molecule diffuses from your alveola into your capillaries, the way your hemoglobin is bound to your hemoglobin, the way that hemoglobin is transported to tissues, which may not always be related to oxygen, it might be related to your cardiac output, is you have a good heart, the diffusion at the capillary, and then the use of that oxygen by the mitochondria. Again, anything can go wrong in that process, and all of this can actually lead to hypoxemia. Alveolar ventilation, which is how much of that oxygen we're bringing in, is important for us to understand that the number one cause of hypoxemia in the PACU is hypoventilation. It's that patient who is deeply sedated or still waking up from some sedative, is not taking enough tidal breath to overcome the dead space. So they're just accumulating CO2 and not getting enough oxygen deep into the alveola, and they become hypoxic and they become hypercarbic. But then the minute you wake them up and you ask them to take a nice deep breath, they recover, they breathe out their CO2, and their PO2 increases. Diffusion of that oxygen molecule from the alveola to the pulmonary capillaries is important. This is why we care about diseases in the interstitium of the lung, fibrosis, pulmonary hypertension. And that coefficient, that diffusion of oxygen is affected by the surface area, the pressure gradient, as well as the diffusion distance. So there's a lot of disease processes that affect any of these three variables, and it will affect your diffusion and lead the patient to become hypoxemic. In fact, one of the disease processes, I'm showing a picture here on the right. On the left, you see mixed venous blood coming into the capillaries. They're getting their oxygen, and they're leaving the oxygen, the lungs well oxygenated. But on the right, you're seeing two things. You're seeing a right to left shunt. So you actually are seeing a true, either could be a cardiac shunt or maybe one of those pulmonary veins, like bronchial veins that support the structure of the lungs, but do not participate in gas exchange. But you're also seeing a diffusion limitation that is affected by the size of that capillary. So that bigger size of those capillary, the bigger the size is, the less likely is for that oxygen to bind freely with that oxygen, with that hemoglobin molecule. So what you're seeing here on the right is one specific disease process that can lead to pulmonary shunt. Can anybody think of one disease process that can lead to pulmonary shunting of that degree? All right, so I am going to show you another picture. I see Dr. Oetner is on the call. So he's doing an agitated saline study. He's getting this 4-chamber view, and he's putting saline into the right side of the heart, and he sees bubbles in the left side of the heart within 1 or 2 cardiac cycles. So in his mind, he's thinking, okay, there's an intracardiac shunt. Bubbles should not be crossing, but I should not see bubbles in the left side of the heart that quickly. So therefore, this is probably an intracardiac shunt. He does it again in another patient, but this time he sees bubbles in the left side of the heart, maybe close to 4 or 5 cardiac cycles. And that's probably a pulmonary shunt. In fact, this is one way in which we diagnose intrapulmonary shunt when we do agitated saline studies and we see bubbles, about 4 to 5 cardiac cycles. I told you the patient is being evaluated for a liver transplant, has end-stage liver disease. What might be one disease process that leads to pulmonary shunting and worsening hypoxemia?
Hepatopulmonary syndrome.
Hepatopulmonary syndrome. There you go. Exactly. So this is the physiology of hepatopulmonary syndrome: is worsening pulmonary shunting because of vasodilators that are not broken down by the diseased liver. We don't really understand the pathophysiology very well, but that pulmonary shunt actually worsens with time. And that pulmonary shunt actually, it's worse on the areas that are better perfused, which is why we develop more shunting when we're sitting upright, because that's where most of our most of our pulmonary flow in our lungs go. So these are the patients who have the opposite than the heart failure patients. So these patients, when they sit upright, they're more hypoxic than when they lay flat. And that's just an interesting finding in that disease process. All right. So again, you probably are going to see this in your boards. And if we're going to talk about oxygen transport, we have to talk about delivery of oxygen. You've seen this before. You've seen the oxygen hemoglobin dissociation curve. Anything that moves that curve to the left increases that affinity. Anything that moves it to the right decreases that affinity and improves delivery of oxygen. So I always think if you're exercising, if you are slightly acidotic, if you're slightly hypercarbic, if you have those mediators of metabolisms that are increasing your lactic acid and all your hydrogen ions, that is moving your curve to the right. Therefore, that oxygen molecule is going to be delivered more efficiently. And I'm showing you 2 graphs. One is the amount of 2,3-DPG that is present in fresh blood, cell saver, and bank blood. And it's just to show you that the blood that we are transfusing when we transfuse a unit of red blood cell is not it's not a good delivery method of oxygen. It lacks 2,3-DPG, which we know moves the curve to the right. And we know that the longer we keep the blood bank, the lower the concentration of 2,3-DPG. So old blood has a lower oxygen carrying capacity than fresh blood or blood that has not been banked for a long time. So that's just something to keep in mind.
The idea there, sorry to interrupt, but the idea there is the cell saver would be the individual's own blood. Is that correct?
Yes, and the cell saver it's exactly it's blood that has not been banked. It's blood that has been collected pretty fresh from when the patient has lost it. You process it, you cleaned it, you spun it, and now you're ready to transfuse it. I would say that in some clinical situations, cell saver might not be the preferred blood to transfuse. You have to keep in mind that cell saver also lacks a lot of other proteins. It's slightly more acidotic. So you just have to be mindful of what context you're going to use, bank blood cells versus cell saver. And again, this is just what we talked about, the PaO2 at 50, which is when 50% of your hemoglobin is bound to oxygen. That's 27 millimeters of mercury. Anything to the right of that is considered a shift to the right. Anything to the left of that is considered a shift to the left. And the thing that boards always like to ask is that all inhalation of anesthetics, including nitrous, will cause a shift to the right. And in acute conditions, a change of 0.1 unit of pH will change 3 millimeters of mercury in your P50 to the right. All right, so you breathe your oxygen, you're not hypoventilating, you don't have any diffusing capacity issues. You may have some natural VQ mismatch because we all have a little bit of true shunt, which is we expect it to be less than 5% of your cardiac output. We already talked about the bronchial veins. We talked about Thebesian veins. So we all have a little bit of a normal gradient, and we calculate that normal gradient with our age in years divided by 4 plus 4. So the older we get, the worse our normal AA gradient, our expected AA gradient will get. So other ways we classify arterial hypoxemia, we talked about hypoventilation, we talked about the restrictive physiology of that patient with abdominal compartment syndrome, that first case. Patient can also be weak. Patient can also have neuromuscular disorders. We talked about the diffusion. We talked about edema, which is actually one of the most common diffusion abnormalities. Excuse me, guys. Colleen, do you mind closing that door? Mine.
Yes. No, not at all.
Thank you.
Yes, yes.
And then VQ mismatch. To the right, that's just an older way of thinking about hypoxemia. So are you hypoxic because you have a low O2 sat that we used to call that hypoxic hypoxia? Are you hypoxic because you're anemic, you don't have great oxygen carrying capacity? Are you hypoxic because you're stagnant? That's a terrible name to tell a patient, but that's usually related to low cardiac output. And then are you hypoxic because you have histotoxic hypoxia, meaning your mitochondria is unable to use the oxygen that is being delivered? So I put that for historical context, but I think it's useful to think about the way we used to think of arterial hypoxemia in those 4 definitions, because it is true. We think of these definitions differently, but those causes still happen today. All right, so definition. So oxygen carrying capacity, remember that most of your O2 is bound to hemoglobin, and that is the 1.34 times your hemoglobin times your percent saturated. So a fully saturated gram of hemoglobin will carry 1.34 cc's of oxygen, and then your PaO2 dissolved in your serum will carry a very minuscule amount. Although if you're really, really anemic, or if you're really, really high in the environment, or if you happen to be in a hyperbaric chamber and you're pressurized to 3 atmospheric pressure, that amount of oxygen that is dissolved in your plasma might just be enough to meet your basic metabolic needs. And that's just because we can do that by pressurizing the chamber. The same thing happens on the venous side. It's the same equation, except you're going to be using your venous O2 sat, and you're going to be using your venous O2 content. The multiplication of your oxygen carrying capacity times your cardiac output is your DO2, that's your oxygen delivery. And then the difference between your arterial and your venous sides over your arterial side is the extraction ratio. So how efficient are you in extracting that oxygen? And we typically think of, a total extraction ratio of our body as being about 25%. If you think about our central venous sats, we want that to be around 75%. But every organ is going to have an extraction ratio that is different. And in fact, that is true. Some organs, for example, the heart and the brain, are going to be extracting a lot of oxygen. In fact, if you were to sample blood from your coronary sinus, that's probably going to be the most deoxygenated blood that you can sample in the human body. And that's because the heart is already doing its maximum effect in using that oxygen that's being delivered. So it has one of the highest extraction ratio that we can measure in the human body. And interestingly, if you look at the brain, it has a pretty good extraction ratio, but the difference in flow between basal and exercise doesn't really change very much in your brain, but it can change drastically in other areas of circulation, like your splanchnic circulation, where your body now will try to shunt blood from your splanchnic area to other areas like your muscle and your heart to tolerate that exercise. So again, think about the extraction ratio. We think about it as a systems, as your central venous sats, but every organ has their own extraction ratio. I'm going to talk a little bit about this. Okay, so we talked about how your heart, the pumping system, is important in delivery of oxygen. So we wouldn't be able to deliver oxygen if your heart was not functioning well. And that is affected both by your afterload, your contractility, and your preload. And over time, as we evolve, the areas that needed to have high delivery of oxygen develop essentially high capillary densities. So things like your heart, where you need a lot of oxygen delivery, has a high capillary density compared to something like your muscles, where one muscle fiber might be supplied by one capillary. And that's just an evolutionary advantage of kind of trying to match delivery of oxygen with the need of oxygen. There are some mechanistic control in how we deliver oxygen to the areas that are needed. So for example, we can increase our cardiac output, but we can also redistribute our own systemic vascular resistance and our own arterial tree to maximize delivery to the areas that are needed. That is true in the rest of the body, although there is one organ in which we might not do it the way we expected, and that's the lungs. The lung is the one organ in which we will be shunting blood away from areas that are more hypoxic towards areas that are better ventilated. But for the most part, the rest of your body will have the opposite control. Recruiting capillaries is one way in which we can do that. We can actually see these capillaries open as the areas of hypoxemia occur, and that could either be activated by local PO2 or by mediators or products of metabolism. So it could be either high lactic acid or high H ions can actually open these capillaries, and that actually, in a way, you're shunting blood to areas that are needing that blood for the metabolic demands. Okay, there are many different ways of monitoring your DO2 delivery of oxygen, and each one has their controversies. We use lactate levels and SpO2 as surrogates of oxygen delivery, as well as surrogates of oxygen consumption, but you can also measure your regional DO2. You can do gastric tonometry. In a way, you can also do your near infrared spectroscopy, your NIRS, that's measuring oxygen delivery, blood delivery into your brain. And then there are other monitors, which we can have one lecture, or we can have a whole symposium of monitors of organ perfusion and organ delivery. And then this one is one that I'm going to not cover very much, but essentially dysoxia, which is, yes, you have oxygen, yes, you have a normal heart, and yes, you have a normal, you're not hypoxic, but for some other mechanism, that oxygen is not able to make it to your mitochondria. So cyanide and carbon monoxide poisoning is one example. One example that we're trying to understand more in the ICU is the excessive tissue edema, is increasing that interstitium distance that an oxygen molecule needs to travel from the hemoglobin to the cell, to the mitochondria. We know that the more edema our patients have, particularly as we de-resuscitate them after we resuscitate them for shock or sepsis, is an independent marker of poor outcomes. So if you have a cumulative fluid balance that is still positive on the third day of your resolution of shock, you're less likely to survive that admission, or you're more likely to stay in the ICU longer than somebody that was rapidly de-resuscitated after the resolution of shock. And part of that is that delivery of oxygen that's affected to your organs. All right, so again, this is your definition for your oxygen carrying capacity. So most of your oxygen is bound to hemoglobin. That's the first part of the equation. There's an oxygen that's dissolved in plasma. That is the second part of the equation. I would just quickly say that a lot of clinical trials, this is actually the ICU ROX trial, which I think was published either last year or the year before that. And just in the couple of weeks ago, in the recent weeks, we've had the hot ICU, which has actually looked at some similar use of restrictive oxygen target in acute respiratory failure patients, and that was published also in the New England Journal of Medicine. I don't have that slides for that article, for that publication in this presentation, but the take home is that it doesn't have any difference whether you are targeting a high PaO2 or whether you're targeting a low PaO2 in the 60s versus 90s on patients with acute hypoxemic respiratory failure. The ICU ROX trial essentially was doing the same thing: is are you using conservative oxygen therapy or your usual oxygen therapy? And there was a very rigid protocols for for patients that were put in each one of these groups, and they were targeting a specific SpO2. This is a non-invasive monitor. It's not a PaO2 like the current trial that I just mentioned. And essentially, there was no difference in ventilator-free days. There was no difference in survival. And then there's no difference in any of the other process measures, like number of patients who needed dialysis or number of patients that needed tracheostomy or other support for chronic respiratory failure. So it made no difference whether you were randomized to a restrictive oxygen target or liver oxygen target. The AOTA systematic review, which looked at 25 randomized clinical trials and looked whether patients with a pretty wide range of diagnosis, including sepsis, illness, critical illness, stroke, trauma, myocardial infarction, cardiac arrest, and they compare the conservative oxygen strategy versus a liberal oxygen strategy. And it actually found that for some of these markers, a conservative oxygen strategy actually was better. And then the Cochrane review that looked at, whether perioperatively should we be targeting a high FiO2, 60% versus less than 40% in the perioperative settings, and looked at 28 randomized clinical trials, including 9,300 participants. And there was really a lot of heterogeneity in this Cochrane review, but there was no sufficient evidence to support the routine use of high fraction of inspired oxygen during anesthesia and surgery. Okay, so that was, we were talking about your PaO2 dissolve. So that was your fraction of inspired oxygen. What about the transfusion target? So we're talking about the bound oxygen, the oxygen that is bound to hemoglobin. Do we know, what do we know about those studies? And that is very nuanced. That we know that the evidence for that, it still is a little vague, but in some patient populations, the evidence might be a little bit better, either because it's been studied or it hasn't been questioned or a little bit of both. But essentially, we always try to keep a transfusion threshold of 7. Anything less than that, we always kind of automatically transfuse. Although I would say that for some patients, we don't always need to respond to a hemoglobin less than 7, as long as they are euvolemic. Euvolemic anemia actually is well tolerated, assuming that your hemoglobin molecule is functioning well, assuming that your heart is functioning well, and you don't have any evidence of any organ dysfunction. But here's a list of other disease processes. Some of these have ongoing clinical trials that will assess whether a different hemoglobin threshold it's better than another. But for the most part, we don't have good evidence for a hemoglobin, in the 7 to 9 range. For the most part, restrictive hemoglobin practices in critically ill patients is better, unless you have evidence of malperfusion, unless you have evidence of ongoing bleeding, in which you might want to transfuse more proactively. Okay, so how much time do I have left? The next speaker is at 4:45 or 5 o'clock? Okay.
4:45.
All right, let's do a couple of these. 32-year-old man is admitted to the ICU with a diagnosis of meningococcyemia and septic shock. He's intubated, he's fever, he's tachycardic. You put an arterial line, your mean arterial pressure is 64, supported with Levofed. He's sedated, mechanically ventilated, PEEP 5. After 4 hours in the ICU, he's not peeing very much. And his CVP is measuring 6 millimeters of mercury, and his central venous sat is 60%. He has a white count. Hematocrit is 28, platelets are 42. So which of the following therapeutic intervention is most appropriate at this time? Do you transfuse? Do you increase levofed to increase your mean arterial pressure? Do you start the butamine? Do you transfuse 2 units? Or do you administer a liter of normal sol? So I'll tell you that some of these questions, like we might want to increase your oxygen carrying capacity by giving them blood, but there's no evidence that a hematocrit of 28 does better than an hematocrit of 32 or 35 in septic shock. I think what they're getting at here is that there's still some evidence that the patient is not appropriately hydrated, either because of low urine output or low CVP, although we're moving away from measuring CVP as a goal-directed therapy. So most of us, what we'll do here is administer a liter of normal sol and look at whether urine output increases or whether there's any other evidence of organ hypoperfusion and trend that as we re-challenge the patient with bolus. Dr. Odner's in this call, so actually another way we can do this is that we can measure our IVC. We can look at our distensibility index and see whether the patient is likely to be fluid tolerant, and if so, with these, we would definitely bolus a patient with a liter of normal sol. Okay, and this is just to show you that we've actually now had 3 landmark papers that have questioned the elements of early goal-directed therapy, such as targeting to a central venous sats over 70. We really shouldn't be transfusion. We should actually be maximizing volume status and hemodynamics before we transfuse. So the right answer for that would be a fluid bolus. All right, the physiologic importance of hemoglobin lies in its ability to combine. What might be the answer for this? Does hemoglobin bind irreversibly with oxygen? Would we be here alive if it did? We wouldn't be here. We wouldn't survive. So at least you can cancel A and C. You know that oxygen and hemoglobin has a reversible, bound. And the question is, does oxygen bind to hemoglobin in the ferric state or in the ferrous state? Okay, ferrous state. Okay, there you go. So each hemoglobin molecule binds 4 oxygen atoms in a rapid and reversible process. The iron may be either in the ferrous or the ferric state. The ferrous state is the only state that can bind oxygen. The ferric state is also known as methemoglobinemia. So that's just one way you might want to remember. Methemoglobinemia, ferric, no oxygen, dysoxia. Okay, every 100 cc's, every deciliter of blood passing through the lungs of a healthy patient breathing room air at sea level will take up 20 cc's of oxygen, 15 cc's, 10 cc's, or 5 cc's. Very quickly, we'll do this together. So again, you want to measure your arterial oxygen content, hemoglobin, assuming that the patient is not anemic, 15, 98, about roughly 100 cc's. And then if you calculate your venous oxygen content is about 15 cc's. The difference between 20 and 15 is 5 millimeters or 5 cc's of oxygen. Okay, let's do, should we do one more? Is my next speaker here?
Yes, I'm here.
Are you my next speaker? I thought it was Marianne Chen. Oh, you're speaking from Marianne Chen. Okay, well, Dr. Orn is here. So why don't we wrap it up? And I'll hand it over to the next speaker. Are there any questions? Okay, all right. Well, with that, I will hand it over to the next speaker. Thank you guys for your time. Really appreciate it. Everyone have a good afternoon.
Thank you.
Thank you.
Thank you.
Okay. So good afternoon. Yes, I'm Clemens Ortner, and I'm very happy to talk to you about focused heart and lung ultrasound. I think there was a colleague who wanted to do a brief announcement before I start. Is she here? Sorry, I forgot her name.
Oh, Alice, she already talked to before Dr. Lorenzo.
Okay, she did. Good. So anyhow, then I will share my screen. Okay. Good. Can you see that? I hope. So I'm happy to talk about to you about focused heart and lung ultrasound in acute dyspnea. My learning objective is how can we use transthoracic ultrasound in a patient that is acutely dyspneic, especially on the ICU, also in the PECU or in the pre-op area. For this, I will give you a background on pulmonary ultrasound. Then we will go through the interpretation of lung ultrasound images. And then I think the most important part of this is actually how we best combine lung ultrasound together with focused cardiac ultrasound to get to a good diagnostic. And I will also use this lecture to do some rehearsal from a previous, I think, CA1 lecture that Marianne Chen did, where she introduced you to some concepts of focused cardiac ultrasound. Yes, and if there's anything that you don't understand, or if you don't see the images, or if you have any questions, feel free to interrupt, okay? Good, so the first, lung ultrasound as a diagnostic test. There's really very good evidence that comparing lung ultrasound with pulmonary CT scanning in order to diagnose interstitial edema, alveolar consolidation, pleural effusion, or pneumothorax, we have a very high sensitivity and specificity, more than 90%. And what also is important, lung ultrasound is actually very much superior to a conventional chest X-ray. So the first question is, which probe to use when we do a lung ultrasound? And I think this always depends on the patient's anatomy and also on your diagnostic aim. For example, if your question is primarily, does this patient have a pneumothorax or not, then it makes sense to use a linear probe with a high frequency but lower tissue penetration, because you want to see lung sliding. Obviously, also the patient's anatomy plays a role. If the patient is very obese, the tissue penetration might not be enough to get to the lung, to the pleura with the linear probe. But on the other hand, if your diagnostic question is if this patient has a lung tissue disease, or if this patient has an interstitial pulmonary edema, so an increase in extravascular lung water, then you need to take a probe with a higher tissue penetration. And this would be either your phased array probe, that can be your cardiac probe, and actually that's the probe that I mostly use for pulmonary ultrasound, or you can also use the curved linear probe. The advantage of the curved linear probe, this is available in many other environments where colleagues, for example, do abdominal ultrasound, like, okay. And then which windows? So in general, there are several techniques. Mostly we use the 8 lung region technique. And which are these 8 regions that you can see here on this image? On anterior mid-clavicular line, in the higher quadrant and lower quadrant, and then also in the axillary line, higher and lower quadrant. 1, 2, 3, 4 on the right side. The same thing on the left side makes 8 regions. If you also include the posterior windows, then it is the 12 region technique. If you just do a quick scanning, and that's a scanning that you frequently might do then on the ICU, where you have more difficult access to the side or also to the back, then you just do the 4 region technique. And you can also do a 28 lung region technique. That is the most comprehensive pulmonary ultrasound. But this is mostly used for to answer academic questions. For our clinical purposes, studies have shown that the 8 lung region technique and the 12 lung region technique absolutely is sufficient for our diagnostics. Yes, some evidence. So here on the left side, you see a histology of a healthy lung where you see the alveoli filled with air. And this looks on ultrasound, you see these so-called A lines. What are A lines? When the ultrasound is coming from the ultrasound probe through the tissue and is then coming on the pleura. And there's a very strong reflection because there's a significant change in ultrasound impedance between the tissue and the air. And so there's a very strong reflection of the ultrasound beam. So the ultrasound beam goes back, reflects back on the ultrasound probe, where there's again a big change in ultrasound impedance. And the ultrasound beam is now bouncing back and forth between the ultrasound probe and the visceral pleura. The same signal is bouncing back and forth, and the machine does not know that this is the same signal. So it calculates it as if the second reflection is coming just from deeper, and the third reflecting back and forth bouncing, the machine calculates it coming from deeper. So the A lines are these parallel lines that are the same distance as from the probe to the visceral pleura. And this is called the A line. So this is, you see, in a healthy, well-aerated lung. If your lung now fills up with fluid, then suddenly you get this kind of B lines. Yeah? These are these comet tails, okay? And these B lines do very well correlate actually with the amount of extravascular lung water. And what is also interesting, this is a study, an experimental study done in pigs, where they have induced an acute lung injury in the lungs. And the ultrasound probes nowadays, they are so sensitive that they saw more and more popping up these B lines, and these B lines were actually popping up before there were any clinical changes, before there were any changes in the PaO2 FO2 ratios. So our B lines, to our lung ultrasound is more sensitive to changes of extravascular lung water than we actually might clinically see. And also what is very good, the number of B lines does very well correlate actually with the wet-dry ratio. And another important advantage of doing a pulmonary lung ultrasound is that it has a much steeper learning curve than, for example, learning cardiac ultrasound. In a recent study, or in a study published last year in anesthesiology, it took 2 hours of video training and 25 supervised scans for novices to achieve a basic competence to differentiate between normal aerated lungs versus interstitial alveolar syndrome, or identifying a lung consolidation. So again, a take-home message, lung ultrasound is much easier to learn than cardiac ultrasound. Okay, so this now looks a little bit busy, but we will now, with this lecture, go through this algorithm, which is an algorithm using pulmonary ultrasound together actually with TTE in a patient that is acutely dyspneic. And so I would like, so the first, we put the ultrasound, the probe on the chest, and how does pleural effusion look like? Sorry. So here, pleural effusion is in general very easy to diagnose. You see here this black anechoic space. This is pleural fluid. And here you see actually atelectated lung, and you see all this black fluid. And you also see this spine sign. So because of this good echogenicity of the pleural effusion, the ultrasound beam is going to the spine, and you can really actually image quite well the spine, and this is called the spine sign. Here, this is how it looks when you have some exudates in your pleural effusion, okay? And then what is also very important, pleural effusion might have a very significant effect actually on your on your cardiac function. in particular in your left ventricular end diastolic filling and in the left ventricular end diastolic area. This is from a study where they have actually artificially also caused some pleural effusion in pig lungs. And you see on the x-axis, the more the pleural effusion is increasing, the more our static pressures are increasing, like the CVP, the pulmonary artery pressures, the heart rate, and in parallel, the stroke volume and the cardiac output is decreasing. And here on the upper part of this figure, you see also the more the pleural effusion is increasing, the smaller becomes the left ventricular end diastolic area as a marker of left ventricular filling. So to sum up, with pleural effusion, we have this will cause a decrease in left ventricular filling, causing a decrease in cardiac output. It's like imitating more or less a pericardial tamponade. Here's the same picture. When you see if no pleural effusion, you see the left ventricular end diastolic area was more or less 11 centimeters squared. And the more the pleural effusion is increasing, the smaller becomes the left ventricular end diastolic area, so as a parameter of left ventricular filling. Here, where you see it's only a third of the original filling. And when they drain the pleural effusion again, you see again that the left ventricular filling is very much improving. So if you have a patient in the OR with significant pleural effusions, the draining the effusion can actually have a very improving effect on the left ventricular filling and on the patient's cardiac hemodynamics. Good. Okay. So the next question, let's say we have excluded our pleural effusion, and then we are asking ourselves, might there be a pneumothorax present? So how do you, any ideas actually how you diagnose a pneumothorax on lung ultrasound? What could be indicators of a pneumothorax? Any ideas? Hello? Anybody out there? Is there anyone listening?
Hey, Dr. Orner, I can give a shot. Turn on my video here. Things I would think about for ultrasounds really would be the absence of the sliding, the kind of the ants on the log type of thing that you would see when you see pleural movement.
Yes, so that is one sign, as you can see here, absence of lung sliding. Anything else that people can think about?
You can get the barcode sign at M mode.
Yes, okay. So that's what we see here. What I want to emphasize, because of course with a pneumothorax you will have an absence of lung sliding, but there are important differential diagnoses that can also cause an absence of lung sliding, like a patient that is apnea, yeah, or let's say when you have a mainstem intubation, yeah, on the non-intubated sides, you will also have an absence of lung sliding. Yeah, that's actually how you might also diagnose it. Or if there's pleurodesis present. Yeah. Also, if there are emphysematous blebs or bronchial obstructions, you might have absence of lung sliding. So what would be now your next step if you see an absence in lung sliding to further, diagnose a pneumothorax?
You can look for a lung point.
Yes, what is that, Meg?
Like the area where lung sliding begins, and you don't have lung sliding at one point, that tells you you have pleural movement at some point in the lung.
Yes. And then, so I will show you this later. And then also, in a healthy lung, you have a lung pulse. When you see these, also here you can see, sorry, on this image, if you follow this here, this is all barcode sign, yeah? And here, now you see this grainy area that shows you this is healthy lung, yeah? This is called sandy beach, okay? And then you see with every heartbeat, we see this vibration is transmitted to the alveoli, and you see this pulse here. And it's even easier to see when you also have an EKG tracing on your ultrasound, okay? So a lung pulse is indicating a healthy lung, and in a pneumothorax, there's an absence of the lung pulse. So, and then, and also the lung pulse can also be sometimes seen macroscopically. Just with every heartbeat, the lung is more or less, you see this impulse on the lung, and this is also called lung pulse. And this is also important. In a pneumothorax, there are no B lines, okay? So even if I said before, a healthy lung looks like you have A lines, a pneumothorax also shows beautiful A lines because you have also this reverberation artifact. And here on the left side of the image, you actually, here you see lung, and here you see on the right side, you see pneumothorax. And this point where the area where you have healthy lung is disappearing, that's, as Meg mentioned, is the lung point. If I go there now. Yeah. And the presence of the lung point, yeah. So you see here, of the left side of the screen is always the lung moving in and out of the image. This is more or less the proof. This is really pathognomonic, and this is the proof of a pneumothorax. Yeah? So when you have the suspicion that there is a pneumothorax, make sure that there are no B lines. If there are B lines, then there's no pneumothorax at this point, and try to find the lung point. When you find the lung point, then it's really the area more or less where the healthy lung is more or less coming in and out. The only exception where you won't find a lung pod is really when you have a very big tension for a large pneumothorax. Okay, so the next question. So now we have excluded, or we have identified maybe some pleural effusion. We have excluded a pneumothorax. Yes, and where are you looking for a pneumothorax actually on the lung? In which areas? And in which areas would you look for pleural effusion?
For pleural effusion, you'd probably want to look in the dependent areas, so posterior if they're lying down, and then kind of the opposite for pneumothorax, maybe like the apex.
Exactly. Okay, and that's also very important. So also when we, not only when choosing, so our diagnostic aim not only defines what probe we are choosing, but it also defines where we start. Yeah. So if you look for pneumothorax, you're looking for air, so that goes up. If you look for pleural effusion or for hematothorax, then you look with gravity. Okay. And the next question is, now we want to really study our lung tissue. So we are checking, are there B lines or A lines present? So B lines, as I've mentioned, are these vertical ring down artifacts. They start at the pleural line and they widen down to the bottom of the screen. That's very important. They really have to go up to the bottom of the screen. Yeah. And they also efface the A lines. And when you have 3 or more B lines, that's what per definition is pathologic. Okay. And why they say these lines have to really go up to the complete end of the screen, because sometimes you see some kind of lines that look like B lines, but they're called these Z lines, and they are not as prominent, and they don't go really to the bottom of the screen. Okay, so that can be, especially for the novices, sometimes that can be mixed up with B lines. Okay, so if you find B lines, then the next question is again a positive B pattern is when you have on one image 3 or more B lines. And then the question is, do you have it on only one side of your lung? Then this indicates either pneumonia or atelectasis, or also a malignancy or a lung contusion, also a focal pulmonary embolism. If you find your B lines on both sides of the screens, then you should actually take a TTE and check for the cardiac function and check if there could be increased left ventricular and diastolic pressure present, causing this pulmonary edema. So how could this look? A cardiogenic reason for increased left ventricular and diastolic pressures can be either systolic function or diastolic dysfunction. How would you rate the systolic function in this patient?
I'm just guessing here, but maybe call it EF like 15 to 20%.
Okay, so yeah, so based on your eyeballing, the ejection fraction is significantly decreased. Is there any other abnormalities that might indicate a decreased systolic function, or that might also indicate actually increased left ventricular pressures?
Is that it's hard to tell, but systolic anterior motion?
What is this systolic anterior motion?
Well, if you're looking
you're
like
on a good path. You're on a very good path. But
mitral valve, it looks like it's actually bending up toward the LVOT. There's the time resolution is a little bit hard to say, but I see one where it looks quite bent towards the LVOT.
So there's the same is when in systole, the anterior leaflet is bounding more or less in the LVOT and is causing a resistance. I would not say that here, but I think your guess was still very good with the anterior leaflet. It's called the mitral septal siltation. So in a healthy heart with low left ventricular and diastolic pressures, the anterior leaflet is really bouncing through the septum. It's more or less touching the septum. And here you see that there's a significant distance between this anterior leaflet and the septum. That's an indicator of also reduced systolic function. And then, and this is a little more subtle sign, but I think it's also an easy marker. How would you say, what's the size of the left atrium here compared to the ascending aorta?
Pretty dilated.
Why do you think it's dilated, or why do you say dilated? I mean, on what, how do you? It's correct.
I'm just looking at the sizes of the ventricle and then atrium, and then the atrium looks pretty, almost like maybe like 80% size of the ventricle. So I assume that's pretty big for the normal person.
Yes, I think that's good. And a thumb rule, just as a thumb rule, the left atrial diameter in the parasternal long axis view is in general the same size as the ascending aorta. So when you see that the left atrial diameter is significant, and here it's more or less double. So that's a marker that probably this left atrial size is increased. And again, the left atrial size is a good indirect marker of chronic cardiac disease. Okay. On the other side, for example, when you see the ascending aorta is significantly bigger and wider than the left atrial diameter, that might be an indicator of an aortic aneurysm. Okay. What markers? So now let's say you said based on your eyeballing, the systolic function is decreased. What parameters do you know? What markers do you know that you could use to further describe and document systolic function? Does anyone have an idea? Yeah.
Like a TAPSE? I don't think you can do it in this view.
TAPSE.
Yeah.
Okay. Do you know for what TAPSE is standing for?
Tricuspid annular systolic plane excursion.
Okay. And so the tricuspid, is this right or left heart?
That'd be the right heart.
Yes, no, it's very good. I mean, the TAPSE is as a very commonly used marker to describe your right ventricular systolic function. Do you know any markers for how to describe left ventricular systolic function?
MAPSE?
Yes, that's correct. It's exactly the same thing. It's just the mitral annulus plane systolic excursion. Any other markers? You see it actually here also in red.
You can PVI.
Sorry?
You can get the VTI and estimate an EF from there.
Okay, the velocity time integral, that's what it's saying. So the velocity time integral is a measure where you measure more or less the blood flow velocity over time through the LVOT. And this is used to calculate your stroke volume. But in the echo reports, what other parameters do they usually report to describe systolic function? It's very simple. Just whenever you describe the cardiac function, you will mostly you hear this kind of parameter.
Ejection fraction?
Yes. What's the formula for ejection fraction?
I would assume it's the end diastolic volume, and then subtract out the end systolic volume, and then divide it by your end diastolic volume.
Yes, correct. And this is the formula for the ejection fraction. And this is three-dimensional, but we have, which you see here, EF, left ventricular end diastolic volume minus end systolic volume divided by end diastolic volume. But it's three-dimensional. That's a little, especially for a focus scan, that's a little bit more challenging. But the same formula, but just use two-dimensional, is the fractional area change. So that's left ventricular end diastolic area minus left ventricular end systolic area divided by left ventricular end diastolic area. So that's two-dimensional. And the same thing, one dimension, is fractional shortening. That's what you see here. So in this patient, he had a fractional shortening of 11. Fractional shortening should be more than 25%. Yeah? So the point I want to make here, if you, let's say, document it and you say, okay, this patient, based on your eyeballing, had a moderately to severely reduced ejection fraction. Based on eyeballing, you said, I think, 20%. You can then also add, and you calculated the MAPSE, and you calculated whatever, one fractional shortening, with which was 11%, further indicating a significant decrease in systolic function. Here, that's also a sign of, I mean, how would you assess, how would you estimate the systolic function in this patient? Any ideas? Does this look okay? Who says it's a normal heart? Who says it's mildly reduced systolic function? Who thinks it's moderately reduced? And who thinks it's severely reduced systolic function?
I'd say it's pretty severely reduced.
Okay. And so probably the reason why this person is still alive is because you see quite dilated left ventricle. So even if the EF is here maybe 5 to 10%, because of this big ventricle, he's still able to produce some stroke volume. You also, as I've mentioned here, you see that the mitral valve is barely opening. Yeah. Again, in a healthy heart, this mitral leaflet should really go to the septum. And then also, as I've mentioned, there's an indirect marker. You see the left atrium here, is also 2 or 3 times bigger than the ascending aorta. Okay, and here do I have another example? Yes, here you see also that the septum is not moving. What I also wanted is a normal myocardium. You should always see a good thickening of the myocardium. Here you see septum, and even here the more apical parts of the lateral wall is almost not thickening. The only part here is more or less the mid-papillary inferior part and the basal part where you still see a thickening of the myocardium. Okay. Good. So if the left ventricular cardiac function is normal, so if the LVADPs are normal, then this would indicate that if you have a bilateral beeline pattern, that this patient has an acute lung injury or ARDS. Or also multifocal pneumonia or interstitial lung disease. Okay, so the point is, when you have a beeline pattern, is it unilateral or is it bilateral? Is it bilateral? Then you have to check, is it cardiogenic or is it non-cardiogenic? Okay, how does a lung consolidation look? If you find lung consolidations, then this is indicating either atelectasis or pneumonia. So how can you differentiate? This is typical for a lung consolidation, for atelectasis, where you see that it's much more homogeneous. You have a volume loss and you have an absence of a dynamic air bronchogram. So if you compare here, it's not very homogeneous. And when you find this open bronchiole, that is an indicator so that the lung tissue is more or less inflamed, but the bronchiole are still open. Then you have this dynamic air bronchogram. Yeah. Again, in a pneumonia, it also is consolidated, but it is much more heterogeneous. You have minimal volume loss and you have these dynamic air bronchograms. Okay. But you can also have actually an acutely apneic patient, and you do the lung ultrasound and you have A lines. Again, when you have A lines, you also want to make sure that you see lung sliding, yeah, because again, the pneumothorax, you will have no lung sliding and you will also have A lines. So now you have the A lines, and then you have to again do a TTE and the venous ultrasound in order to check if there might be pulmonary embolism present. So a venous ultrasound, you would, on the big veins, you would look if you find either some thrombosis, when you either see the clot, or which you can see here, or let me, on this right image, the lower is the femoral vein, and you see how it is compressible. In the middle image, even if you don't, it is difficult to identify the clot, but you see that you cannot compress the vein. So this is a marker that there might be some thrombosis going on. And if you do the TTE, you will see in PE, especially in particular in a fulminant PE, you will see a right ventricular dilatation, like here. So here, sorry. I apologize. So you see here the left ventricle is significantly smaller than this ballooning right ventricle, and you also always see this bouncing septum. The septum in theory, in a healthy heart, the septum should always be convex into the right ventricle. But here, when the right ventricular pressures with a fulminant PE are increasing, you see this called this D sign. That's the D sign. And you also here, this is an apical four-chamber view where also you see this ballooning right heart and the very empty and small left heart, because the right heart is not able to get the blood from the right side over the lung to the left side. And you might also actually have a significant TR jet. So when you put a color flow in this heart, on the right heart, on the tricuspid valve, you see suddenly the blood flow and systole going from the right ventricle into the right atrium. And when you now put a continuous wave Doppler line through it, you will get a pressure gradient. So this is then the curve that you get, yeah, where you measure more or less, not more or less, you measure with the continuous wave Doppler the velocity of the blood going from the right ventricle into the right atrium. And here in this case, the velocity, the peak velocity is 3.17 meters per second with the so-called Bernoulli equation, which is 4 velocity squared. It gives you a pressure gradient. Yeah? So you have the pressure gradient between the right ventricle to the right atrium of 40 millimeter mercury. When you add the CVP, this gives you then actually the systolic pulmonary artery pressures. Okay, I hope it's not, not too complex, but it's a quite. That's actually how in the echo labs they calculate you the systolic pulmonary artery pressures, and it's not that difficult to do. Again, when you have a good apical four-chamber, you put the color flow on your tricuspid valve, see if there's a jet, and if there's a jet, measure the flow velocity. With the peak flow velocity, it gives you a pressure gradient. Okay. So, and you have excluded, so your venous ultrasound was negative. You checked you did your TTE, and you found no right ventricular pressure. But another reason for dyspnea with an A-line pattern could also be pericardial effusion tamponade. The effusion is quite easy to identify. It's also this black fluid around the heart. You can quantify it. Yeah, it's small, moderate, or large effusion. So the amount of the fluid is not that important. The main importance with pericardial effusion is the time, how long it takes that this effusion develops. And then the next question is it effusion or is it tamponade physiology? So what are signs of a tamponade? That's when you have a collapse of the right atrium. So don't forget that the pressure in the right atrium over the cardiac cycles are the lowest. So the right atrium will be the first part of the heart where you might see a collapse in tamponade physiology. You will also then see a dilated IVC. And in the more severe the tamponade physiology gets, then you will also see a right ventricular collapse, and in the most severe also an LV collapse. You will also see a swinging heart that causes also the electrical, the change of electrical vector on your EKG, and yeah, that's, I would say, the most important thing. But let's look at some images. So here in this, there you see always this bouncing collapse of the right atrium. So this is a sign that this is not only an effusion, there's tamponade physiology present. And also here you see this bouncing heart, yeah, this swinging heart. Here also, this bouncing heart, you see that the right ventricle might be also a little bit collapsing. And last question, can anyone tell me, how do you differentiate between a pleural effusion and a pericardial effusion?
So I think you look at the descending aorta there, which is kind of centered on the screen, and a pericardial effusion will be superficial to the descending aorta, and a pleural effusion will be deep to it.
Yes, exactly. So here we have our descending aorta, and the pleural effusion is anterior to it, is an indicator of pericardial effusion. effusion posterior to the descending aorta is pleural effusion. Okay, so I hope that I wanted to present you more or less a decision tree, how to evaluate a patient that is acutely dyspneic. I hope I was also able to give you some background, some theoretical background on the pulmonary ultrasound, and also to share with you images, how to interpret different lung ultrasound images. And last but not least, I really want to emphasize the usefulness when you do a lung ultrasound and you identify an abnormality to combine it with doing a cardiac ultrasound. That gives you really the most information and diagnostic benefits. Thank you very much. Are there any questions?